in our group are myself, Tracy Beeran. We have Lindsay Shreve, Alexandra Black, Nicole DeMerchant, and Janet Wolozanek. And we're going to go ahead and start. So just to give you a little background of our scenario, you are the preceptor for Tommy, a nurse practitioner student who is assigned to perform a physical assessment on a 45-year-old male, Ron, who presents to the emergency room with complaints of shortness of breath and chest pain. You observe Tommy's assessment of Ron and note that she failed to complete 2 areas of the assessment. Following the exam, you are reviewing Tommy's chart notes and observe that she did chart all areas of the exam as being completed. When you point out to Tommy that she skipped 2 areas, she becomes very upset and insists that she did assess those areas and that you must have been distracted and not seen that part of the exam.
Tommy, I'm glad we can talk in private for a moment. I think we should talk about the exam and charting for the patient, Ron.
Okay, is there anything that I need to improve on? I'm honestly feeling more comfortable with my hands-on skills, and the charting is certainly becoming easier.
Well, when you were doing the exam, I didn't see 2 areas that you had documented as done. I know sometimes it can be confusing with the EHR documentation, but no and normal imply that exams or questions were done. So it's just important to keep in mind that if you do a problem-focused exam, we only document what was done in the chart.
What are you talking about? I understand the difference in documentation and that no is different from a normal finding. I know that I assessed those areas and I documented them appropriately. You must be mistaken. You were probably distracted and just didn't see that part of the exam. Maybe you were looking at your phone.
All right, Tommy. So when we're doing the exams going forward, I'd really appreciate it if we just start talking and explaining to the patient what part of the exam is happening. I think this will help with the patient comfort. I also think it would prompt anybody in the room who may not be paying attention completely to grab their attention and let them know exactly what's going on and keep us all on the same page.
I understand what you want, and I'm willing to do the exam your way. What you want me to do from now on is when performing the exam, I am to talk to the patient so they know what part of the body I am examining. Is that correct? At least I think it is. I still think that you didn't see those 2 parts of the exam that say I know. I think the documentation should be kept as I wrote it.
So what I'm asking you to do is just explain to the patient that now I'm going to listen to your heart or listen to your lungs so that we all know what part of the exam is being done and the patient is aware of what we're doing. As for the documentation, I want you to keep in mind that while we're in clinicals, we're working together as a team, and I'm trusting your skills as a provider to assess the client, working through the development of the plan, and that we are documenting collaboratively. I want to have open communication and respect so that when we're doing this, we can grow together during this time. Ultimately, though, the documentation must be something I am comfortable with since that is under my name.
Well, you are right. It is your name on the documentation. If you feel you need to change the documentation, I will trust what you are telling me. I will try and be more aware of my documentation going forward. But are you going to talk to my school about this?
Tommy, since this is the first time we've had this issue and we're having this discussion, I think we're going to just try to fix this amongst ourselves. But if it's something that continues to happen, then we're going to need to bring in the faculty.
Okay, thanks. I'll keep that in mind.
When looking at this particular scenario, there are clearly several ethical and legal considerations at stake. Looking at ethical considerations, we're considering the 4 general ethical principles being autonomy, beneficence, non-maleficence, and justice. Beneficence and non-maleficence clearly come into question. Beneficence being the obligation of service professions to provide a good to those served or striving to meet the professional duty of care for patients. Non-maleficence doing no harm in the process of practice or ensuring that necessary harms are minimized and do not outweigh the benefits of the action. These 2 clearly come into question. Well, looking at patient safety, not addressing the issue puts the patients at risk. Patients trust that they are receiving optimal care from competent healthcare providers. Incomplete assessments are clearly not optimal care. Allowing or ignoring this omission breaches the preceptor's duty to care for the patients and the students, to provide appropriate support and supervision to the student, to promote respect for personal and professional integrity, and ensure a good clinical experience for the student. It risks the student's education, health, and well-being. The decision to address or not address the issue may impact the student's grade or future. It may hinder the student's goals to gain experience, to practice nursing skills, maintain a safe standard of professional behavior, and keep professional integrity, and also cause significant distress or guilt, and may negatively impact students' professional behaviors and attitudes. Furthermore, looking at power asymmetries among lecturers, students, and clinical colleagues, the student may feel the preceptor is being too harsh or possibly even unfair, which can impact the student's behaviors and attitudes also. When looking at professional and educational accountability, this compromises the credibility and effectiveness of the educational program or school, employer, and the profession. For example, passing someone through to graduation and further employment without the skills or integrity expected reflects poorly on the school to the employer and the provider to the patients, and the provider to the profession itself. Moral virtues, which are character traits that dispose someone to consistently think, act, and feel in certain ways, example, doing what is kind or doing what is honest. Good character virtues for professional nurses include fidelity, courage, integrity, compassion, justice, and practical reasoning, some of which are clearly put to the test in this scenario. According to the International Council of Nurses, nurses ought to take appropriate action to safeguard individuals, families, and communities when their health is endangered by a coworker or any other person. Therefore, preceptors must take a stand against unsafe practices by students. As far as legal considerations, legal ramifications are subject to scope of practice, state and federal laws, and licensure specifics. When not followed, it opens the provider to litigation, reprimand, loss of employment, or loss of licensure. Preceptors are legally responsible for the safety of the patients and overseeing the student's care. They're liable for any outcome of any act that has been delegated to the student by the preceptor. Charting that was not actually done is falsifying the patient record. Being negligent in caring for the patient by not doing an appropriate assessment, which is not doing what a prudent nurse would normally do, which also exposes the preceptor to litigation. Malpractice and poor professional behavior have significant implications on the quality of care that is provided to patients, relatives, staff, and the profession. It poses a financial burden to the student's educational program that is charged with providing liability insurance for the student. And finally, it's important to remember that patient safety must be viewed as the greatest good.
To address this preceptor situation, our group decided to utilize Torn and Wagner's ethical decision-making tool from the 2010 article on ethics in nurse management. Step one was to define the ethical dilemma. This ethical dilemma revolves around two issues: the student charting something that wasn't done, and then also possibly being dishonest with her preceptor when confronted. The concern is then, how should the preceptor address this? Step two is to clarify the personal and professional values, ethical principles, and laws involved. Lindsay just did a wonderful job discussing the legal and ethical concerns for this scenario, as well as the personal and professional values that are relevant. Step three, identify the alternatives for action. First, addressing the situation immediately with Tommy, making sure she understands the seriousness of our concerns, and then follow up and monitor Tommy, having clear expectations, likely increased supervision, continual assessment of the problem and her efforts to resolve it, reporting to faculty if her behavior remains unsatisfactory. We did note a missed opportunity to correct or guide the student immediately during the assessment, so the exam would have been more thorough. This would assist the student with learning the proper procedures and preventing poor practice. In this instance, this would prevent charting something in error because it wasn't skipped, but doesn't address the fact that the student is willing to lie and the integrity issues. That would have to be caught elsewhere. Another alternative is to ignore the problem altogether. This poses the above discussed legal and ethical threats to the student, school, preceptor practice, and to this and any future patients. Or we could report the student to the school's faculty without talking to Tommy first. This may be premature and potentially compromise the preceptor-student relationship and the student's ability to move forward in the program. However, as stated before, the relationship is less important than the ethical and legal responsibilities of the preceptor. So if after taking steps to resolve the issue, the behavior is not modified, the preceptor must inform faculty. Step 4 is choose an action. We chose addressing the situation immediately when observing the incorrect charting. This needs to be handled thoughtfully to try and preserve that relationship. While uncomfortable for both parties, it'll hopefully be a learning opportunity, set boundaries, establish respect, and allow the student to model appropriate behavior in future patient encounters. We recommend talking with Tommy in private and explaining the implications of her actions, which she may not have realized, including patient negligence, legal documentation issues, being respectful in her role as a student, and the preceptor's role and responsibilities to Tommy and her patients, which Nicole and Alexandra just role modeled for us. We need to acknowledge Tommy's likely anxiety and her need to appear that she's right and fully competent as a student. Explore her reaction of defiance when the preceptor pointed out her errors, and explain that she must be open to critique and understand that it's part of any learning process. Being honest is necessary to foster a good relationship between the student and teacher. Work with Tommy to set some goals for the next few weeks regarding patient assessment, documentation, and receiving preceptor feedback, and be sure to remember to give her positive reinforcement during this time too. Step 5 is to initiate discussion about unresolved issues. So when addressing the issue immediately, unresolved would hopefully, if it progresses well, there'd be only a need for follow-up and supervision. If she's receptive and modifies her behavior appropriately, the issue is resolved. If not, further guidance is needed, probably with faculty involvement. There's also the possibility of resentment or awkwardness affecting the relationship. Clear communication and positive interactions can help, but again, remember, we're trying to preserve that relationship and we don't want to ruin someone's chances of graduating and the financial concerns that would come with that, but that's less important than the ethical and legal responsibilities of the preceptor concerning this future provider. Step 6, generalize the solution to other similar cases. For this assignment, we only have the one scenario, so it's not entirely relevant, but the broad principles can be applied in our individual practice or teaching environments anytime we see something we're uncomfortable with, pondering the problem if necessary to see if it's just personal discomfort or are there legal, ethical, and professional issues that we can identify that require being addressed. If so, address them promptly and professionally, and if the violation is severe enough, it may warrant going up that chain of command immediately instead.
So as you can all see from everything that we talked about, there's a lot of balancing going on here. And we chose several strategies for the preceptor to respond to this particular dilemma. One of the overarching principles was using the virtuistic approach, which includes compassion, integrity, justice, and due process, and practical reasoning. So, exercising compassion for both the student and the patients, with patient safety superseding everything, including compassion for the student in this particular scenario. Integrity, the preceptor cannot ignore this issue, and she must model trustworthiness and consistency for herself, the student, and the profession. Exercising justice, providing due process for the student by giving timely and constructive feedback to her in private to ensure resolution and continuity, providing an opportunity for the student to respond to the situation and voice her own concerns, and providing opportunities for improvement, including offering an objective, which would be focusing on a specific goal for the student in future patient encounters to ensure follow-up and behavior change is taking place. And finally, communicating problems to faculty only if needed. Promoting utilitarianism, which is promoting the greatest good for everyone involved, which in this particular scenario included the patient, student, and the preceptor. Using practical reasoning by identifying, interpreting, and adapting moral considerations to the scenario. And balancing critique with positive feedback for the student. So in this encounter, it was important to ensure that the student didn't feel picked on, and that the preceptor does appreciate her positive contributions, while also making sure that we do address this issue. And finally, ensuring that the student understands your role as the preceptor and make sure that both she and her patients are getting the care that they deserve. And just to go over portion of the assignment was contributed by each member of our group. All of us did contribute equally to the assignment, but just to break it down, Janet did a lot of research on the decision-making model. Alexandra played the role of the student, and she and Nicole coordinated the script to role play our scenario. Nicole had the role of the preceptor. Myself, I was the group leader and just went through articulating the strategies of the preceptor to respond. And Lindsay researched and articulated the ethical and legal implications for the scenario. And that wraps it up.
Thank you so much, guys. That was a wonderful scenario and how you presented it.
Yeah, great job.
Thank you.
I enjoyed that.
Thanks.
Thank you. Does anyone have any questions at all?
I do have a comment. I think this is something that I have seen in the clinical setting. I work in the ICU, and it's such an important issue when things are charted that are not, assessments are not done and they are charted. I've seen patients herniate because the nurse did not assess properly. And literally within a couple of hours, and it's just too late. And charting is there and it's done, but the assessment wasn't done. So thank you for discussing this ethical issue.
I think sometimes when these things happen, when you have a student who is so defiant and is putting your own practice at risk by not documenting properly or not wanting to hear feedback, then it can also make people not want to take students, which then is a disservice, of course, to the profession in itself and the future students. So how do I put this question? You guys did a really good job, so it's hard for me to find honestly a good question to ask you. But overall, when you're managing a student who's like that, who it's beyond her understanding, his or her understanding, but it's rather that they are adamant that to defend their behavior. I know you mentioned addressing it with them first prior to going to faculty. But are you concerned at all that this is a personality thing as well?
We did talk about this quite a bit, I think, because the scenario we thought was a little bit vague in that department, whether I know that I had brought up, is the student lying, like actively lying about what she did, or was she stressed out and maybe she thought she did do it, or in reverse, maybe the preceptor did look at her phone. I mean, I don't know. So is she just being defiant but truly believes that she did that? And then we talked about, like, it said 2 areas of the assessment got missed. So was it 2 little check boxes, or was like she documented an entire cardiac exam that was clearly not done? It kind of makes a difference. But yeah, the integrity, I think, makes a big difference. If she's just doing something wrong and that skill can be taught, I think a lot easier than an adult will willingly learn integrity. I don't know. Does that make sense?
Mm-hmm.
I mean, it's something you kind of either have or you don't. Then on the flip side, I'm like, well, I want to be super judgy, I guess, if I hear about somebody not, assessing an ICU patient and then they have this huge outcome, but I'll be the first person, I'll get kicked out of the program here. I have documented a respiratory rate that I didn't actually, I looked at them and I put 16. Okay. Like I didn't necessarily, they were talking to me, they were fine. It's like a local procedure, take an assist off or something. I'm sure I've done it. So where's that line? And yeah, the integrity, that's why we said if we had addressed it immediately during the assessment that she didn't do those things, like they were required, which is another issue too. Was it something that had to be done for that patient's complaint, or did she just document a whole assessment? If it was required and you did it, then okay, then that would have prevented that. But if it's really an integrity problem, then that wouldn't have, caught that. You'd have to find that somewhere else, I guess. And that to me is kind of more concerning than the skill, which I assume they can, if they've made it this far in the world of education, that they can pick up the skill at some point.
But I think like overall, as the preceptor, you want to have like a plan going forward with that student. And I guess what I'm thinking that is it'd be like goal setting. So you come in the beginning of the day, you set your goals, and I guess one key point for Tommy would be, okay, this is how we're going to proceed. You're going to tell me in the exam which body part you're examining, and go forward from there, just to make sure nothing is missed. And maybe if that is a skill that is repeated over and over and over, hopefully that will become a habit and a way to instill that they will then be documenting appropriately.
Yeah, I really like that solution that you guys came up with, because I felt like it was not accusatory, but still also made sure that she was going to be doing the necessary assessments, and that there would be no loop in conversation, because everybody would have an opportunity to make sure the patient would benefit from knowing what's happening to them, the preceptor would benefit from ensuring that the proper care was done, and the student would also benefit from almost like this feedback loop of, I'm speaking, but then I'm also reminding myself of what I need to be doing. And so I think that's really, really great approach.
I just wanted to chime in on what Janet had said. I definitely agree that you really have to take each individual scenario and, consider that before you could act. Like you said, is it an integrity issue versus if it's something that was perhaps a mistake or something that wouldn't necessarily, I don't know how to word this without sounding biased, but like you said, if it's not going to result in a huge outcome, maybe just providing a more simpler form of education on using caution about doing that. Don't make that a habit. I noticed this, etc. One thing I want to point out is that I liked how moving forward, you guys suggested you were going to offer positive reinforcement for her. Because I can only imagine if that was me, I would not want to come back the next day. I would be, if I did it intentionally, I would be very embarrassed that I got caught. And if I didn't do it intentionally, I would either think you were out for me, or either that, I just made a huge mistake, one or the other. So I thought the positive reinforcement going forward is a great idea.
I noticed that she got defensive at first, but after she was told that the faculty was not going to be contacted, she kind of slowed down a little bit and was a little nicer. So, I think that happens very often with students, for sure. They get defensive, and we feel it's an attitude where really, she's basically worried about her academic career there.
I think it all comes down to patient safety, which is the most important thing. And whether the student was incorrect or the preceptor was incorrect, I think the important thing is making sure that it's done. So regardless, I think it would be up to them to go back to do it again, just to make sure there's no question of it being done or not. I think, like we all said, that patient safety supersedes everything. So regardless of who was actually in the wrong, it needs to be done. It's as simple as that.
I agree. That's a great point.
Does anybody else have any comments, questions before we allow the next group to move forward?
Looks like Nicole is trying to say something, but we're not able to hear her.
Nicole, if you want to type, maybe one of us could just read it out to the group. So basically, this is Nicole. I was just saying that I feel staying calm and not battling with the student was essential.
Absolutely, because I think the preceptor could have easily lost their cool in that scenario. So that was definitely a really good way that you guys acted that out and showed true decorum throughout that whole process.
I agree, and I think it kind of goes with what somebody was saying earlier about kind of the stress that students are under and the pressure to perform, and am I doing this right, and am I doing, everything I'm supposed to be doing, and you're working really hard to learn all this stuff. And so sometimes, it can be a little intimidating, and when somebody says like, oh, you didn't do this right, or you didn't, so I think the preceptor to be the calm in that, and hey, it's okay, let's figure out how we can fix this going forward.
All right, so we're past the 25 minutes now. So we'll go ahead and begin if you guys are ready. All right, so our group comprises of myself, Kathia, Katrina, Carla, Whitney, Heidi, and Sharnaz. I'm gonna go ahead and begin. You are the preceptor for Mandy, a nurse midwife student. Mandy has been with you in the prenatal clinic for 2 months and is competent and caring student. Today you are meeting with Katrina and her partner Rick, who is a trans male, a man who was assigned female at birth. They are expecting their first child in 3 months, just moved to the area, and are looking for a midwife. Katrina shakes hands with Mandy when she introduces herself as the student nurse midwife, but when Rick reaches to shake Mandy's hand, she quickly pulls up her clipboard and just nods at Rick. Now we're going to discuss the ethical and legal aspects of this scenario and how the preceptor should respond.
Hi, Mandy. Can I speak to you privately?
Sure.
Mandy and the preceptor step aside for privacy where no one could hear them.
Mandy, let's talk about the encounter you just had with Katrina and Rick. Do you think it went well, or is there anything that you would choose to do differently?
Overall, I think it went pretty well. I will admit that I was pretty uncomfortable with Rick and Katrina's relationship.
What about the situation made you uncomfortable?
I have never had to take care of a same-sex couple before, and I don't know that I have had any interactions with transgender patients.
I noticed you seemed to be uncomfortable with shaking Rick's hand. Do you have any moral, cultural, or religious beliefs that make you uncomfortable in this situation?
Oh, I didn't even realize I didn't shake his hand.
Sometimes we can exhibit unconscious biases. How do you think this situation could be interpreted and potentially affect the delivery and perception of care from Rick and Katrina's viewpoint?
That was not my intention, but perhaps you're right. If that were me, I would feel judged and have a hard time trusting and being forthcoming with my provider.
That is a great point. I would also like to add that there could be ethical and legal implications, particularly if the individual felt discriminated against.
Let's take a moment to pause and hear more about the ethical and legal implications from our expert on this subject.
Working in healthcare teaches us that one cannot effectively administer proper care to the patient without addressing and engaging the individuals who have the greatest impact on their overall well-being. There are several ethical issues that are at play in this scenario. Firstly, transgender people have the right to have their self-identification respected by staff. Providers should consider the role of the partners in incorporating a social support network that validates the patient's identity. Secondly, non-maleficence implies a commitment to minimize harm to patients. Harm includes barriers to the accessibility of care and the perpetuation of stigma and discrimination. Thirdly, benevolence implies addressing barriers to care and healthcare disparities on both the population and individual levels. The approach should be understanding and non-judgmental. Cultural sensitivity and awareness of the proper usage of pronouns will demonstrate that the provider is being respectful. Lastly, the Code of Ethics for nurse educators includes the following. 1, the preceptor must model high standards and expectations. 2, she shall safeguard the patient from incompetent, illegal, or unethical practices of others. And finally, she must demonstrate respect for the beliefs and rights of the students and their participation in nursing research and practice while evaluating them with fairness and integrity. Several laws and policies protect transgender people in healthcare, one of which is the Affordable Care Act, or Obamacare. Under the Affordable Care Act, it is illegal for most healthcare providers to discriminate against you by turning you away or refusing to treat you according to your gender identity. It is also illegal for healthcare providers that receive federal money to do any of the following because you are transgender or because you don't conform to gender stereotypes. They could not refuse to admit or treat you. They can't force you to have intrusive and unnecessary examinations. They cannot refuse to provide you services that they provide to other patients, refuse to allow you to the restroom consistent with the gender with which you identify, harass you or refuse to respond to harassment by staff and other patients, and isolate or deprive you of human contact or limit your participation in social or recreational activities. The Health Insurance Portability and Accountability Act, or HIPAA, protects patients' privacy when it comes to certain health information, including information related to a person's transgender status and transition. State and local non-discrimination laws prohibit healthcare discrimination against transgender people. In fact, a large number of states have explicit policies that prohibit anti-transgender discrimination in private insurance and Medicaid, such as exclusions of transition-related care. There are Medicare and Medicaid regulations which protect the right of hospital patients to choose their own visitors and medical decision makers, regardless of their legal relationship to the patient. This means that hospitals cannot discriminate against LGBT people or their families in visitation and recognizing a patient's designated decision maker. The Joint Commission Hospital Accreditation Standards require hospitals to have internal policies prohibiting discrimination based on gender identity and sexual orientation. So with respect to Mandy's interaction with Rick, it is unclear whether her behavior is illegal. However, if Rick felt as though Mandy's behavior was discriminatory, he has the right to do the following. He could sue the healthcare provider, seek legal aid or legal service organizations such as the Transgender Law Center, and lastly, they could choose to file a complaint with the Office for Civil Rights at the U.S. Department of Health and Human Services. It is important to note that under the Trump administration, the HHS has said it will no longer investigate complaints about anti-transgender discrimination.
So moving forward, let's talk about ways to overcome unconscious bias to provide ethical and culturally competent care by hearing from our expert in this subject.
Cultural competency is the ability to understand, communicate, and interact with individuals across different cultures. Given the diversity of the United States, all individuals need to exhibit cultural competency, but especially people working in human services like healthcare providers. Cultural competence is especially important for healthcare providers because patients who do not receive culturally competent care are at higher risk for negative health consequences and receiving poor quality of care. Tips for improving cultural competency include recognizing that culture extends beyond skin color. Find out each patient's cultural background. Conduct culturally sensitive evaluations. Elicit patient expectations and preferences, and also be aware of your own cultural background and bias. Becoming culturally competent is not an instant change, but rather a process.
Now, let's discuss the framework chosen to resolve this dilemma.
We used an integrated model consisting of 6 steps with useful questions and tools that help improve performance in each step. Step 1, identify an ethical problem. Perceive the problem and create a problem statement. Determine if this is truly an ethical dilemma based on ethical values such as autonomy, beneficence, non-maleficence, justice, etc., versus a communication issue or legal issue, etc. Characterize the problem by asking, is the problem of high, medium, or low urgency? How greatly does the decision affect the patient's health status and quality of life? Does the ethical problem already exist, or is it likely to occur? What other information do you need to understand the problem and solve it? Step 2. Collect the additional information to identify the problem and develop solutions. Who is involved in the problem? Do they have all information needed to establish their own perspective? If not, provide them with the needed information. Consider biological information, such as diagnoses, etc., psychological information, such as culture, values, beliefs, and social aspects. Who is ultimately the decision maker? Is the problem statement stated in step 1 correct? If not, correct before proceeding to step 3. Step 3. Develop alternatives, analyze, and compare. In analyzing and comparing the alternatives, consider these aspects. Ethical rules such as fidelity, veracity, confidentiality, ethical principles such as autonomy, non-maleficence, beneficence, and justice, ethical theories such as utilitarianism, virtue ethics, etc., professional ethics such as guidelines for patient practice, codes of ethics, legal aspects, personal conscience or religious of the healthcare professionals, guidelines and policies of the institute or society values. Step 4. Select the best alternative and justify your decision. Find a solution with which most parties, including the patient, are satisfied using the process of analysis and comparison. You must be able to justify your choice by reasonably respond to different opinions. To examine whether we are confident with our decision, we can ask, is the chosen alternative consistent with my value or the institution's value? Think about an opinion that does not conform to your choice and challenge it. Answer the following questions. If the chosen alternatives were implemented, the legal test. Is the chosen option consistent with law? Front page test. What if this case were published in one of the popular newspapers? Gut feeling test. Is your decision consistent with your gut feeling? Role model test. Is an RN you respect likely to make the same decision? Professional standard test. Is your decision acceptable to the nursing profession? Step 5. Develop strategies to successfully implement the chosen alternative and take action. Actualize the ethical decision. Do not restrain ethically correct decisions and instead find the best strategies to support it. Everyone must actively participate to implement the decision, regardless of whether it is one he or she originally intended. Step 6. Evaluate the effects and development of strategies to prevent a similar occurrence. Evaluate the effects of any chosen action and decision-making process. Consider other strategies if the expected outcomes are not achieved. If the ethical problem is solved, develop strategies to prepare for similar problems in the future.
This concludes our ethical and legal role-play scenario. As you can see, practicing the tips described is a step in the right direction towards Mandy becoming a more culturally competent healthcare provider. We can now discuss and answer any questions.
Wow, good job, guys. That was wonderful. And I really liked the beginning. I think it was Heidi that started the whole conversation after the scenario by asking Carla, so how do you think that went? I thought that was a really good way to kind of open up the conversation and, just to kind of get, her feelings on, how did that go? What could you have done better? I thought that was a wonderful way. And I'll remember that in the future when you're addressing concerns with students. So I thought that was a very good, a good point of that.
Thank you.
I did wonder at the beginning, I couldn't remember if the scenario had said that this was like a long time couple with them, or if it was like their first one. I guess as I probably would butt in then, honestly. And I'd been like really not obnoxious, but a little extra about it, like shaking his hand and trying to make them unusually comfortable. Not like point it out, but just make sure that it wasn't, because, you know, like she said, she didn't even realize she didn't do it. Maybe she was just a little uncomfortable. It wasn't necessarily a conscious decision, you know, come in behind and like shake hands, whatever. But then again, if, you know, they've already been my patients for a year, that'd be super weird. So how would you deal with it then? I guess to when you come into a situation like that, it is hard not to be uncomfortable when it's different than what you're used to. Just like anything, we go into any situation that's different. I guess, do we make an effort to just be more than we normally would be polite to make sure there's no feelings hurt, or is that too much?
I think we often do. I think sometimes when we recognize we're uncomfortable, we sometimes overcompensate, and then I think we end up going on the other end as well. You know, there's a fine line between undercompensating, overcompensating, and just treating them like you would treat anyone else. You know, not even using the terminology them, but treating everyone equally.
Janet, your point there, that was kind of something that we all discussed quite a bit in the beginning of this was, you know, did she even realize what she was doing? Did she have biases? You know, we spent quite a bit of time talking about that, you know, because when we first read this scenario, it was like, oh, how dare she do that? You know, I think we all kind of had that same, you know, idea, but then as we kind of dug into it, everybody kind of, well, maybe it wasn't really just, you know, what wasn't her religious belief. Well, you know, we even ran with that for a little bit with going with this. There's so much that goes into it. I think that really showed, you know, us that.
Yeah, I do think that's something we have to be careful. I've talked about this with like my kids and whatever, especially any group that, and who does, most people, I guess, belong to some group that's gets marginalized in some way. Women, nurses, you know, yeah. Color, sexual orientation, all sorts of things that I don't want to offend somebody. I don't know how to say this without, like, I might be having a bad day and I have a headache and I'm just mean, like a bad person that day, and it has nothing to do with any of those things, but then naturally they're probably going to identify with it that way because that's been their experience. So I guess that goes with that whole leave your problems at home. Yeah. So, you know, you can just be a person who slights somebody, or, you know, there doesn't have to be a reason that we're mean.
Yeah.
Not mean, but mean's not the right word. You know what I'm trying to say. Mm-hmm.
I mean, yeah. It's tough because she shakes the hand of Katrina, but doesn't shake the hand of Rick. And so that it almost, regardless of how that person might have been feeling that day, it automatically is going to come off personal to Rick, even if he's trying to be understanding. He's going to say, well, look at that. She just totally disregarded me. So sometimes, even if we are not intentionally trying to be hurtful to people, we just have to be mindful that it could be our facial expressions. It could be the way that we're interacting with the individual. I mean, it's just body language. And sometimes it's difficult because you're not even aware of your biases or your stereotypes or anything like that. But it can affect somebody else, and it can cause them to maybe not work with you anymore, or take it up, as we mentioned, to a legal standpoint where this is discriminatory. So it's just constantly having to be conscious of, you know, what we're doing.
I just wanted to read Nicole's comment back when we were talking about compensating. Nicole said, yes, when we try to compensate, we may make something more obvious than it was to the patients.
Mm-hmm. I just wanted to add, like, alternatively, what we can do with the student maybe is, because you know you're going to do a chart review before you ever walk into that patient's room, her and her partner. And, you know, it may or may not be noted in there that the couple's orientation, but maybe before going into the room, they talk about their own biases, like the preceptor and the student. Let's examine that before we go into the room, just to bring an awareness to it.
I think that's a great point. If you have the opportunity to actually to do that, to explore the students' perceptions, whether they're conscious or unconscious. Yeah, I think that's a really good point.
I think that's a great point.
One thing that we didn't mention in the role play, but I thought was interesting upon our research, was just how often or how prevalent it is that transgender individuals experience either they're getting dismissed in the medical setting, like people may not want to treat them, or they're treating them poorly. If you can imagine, sometimes if you're coming into a new provider per se, you're coming to meet them for the first time, and you've experienced this in the past, you automatically might be cautious to see how someone may treat you. And then when something like what happened in the case with Mandy to Rick, it really can set a precedence that that can affect that entire relationship that may not be able to fix, later. So,
and to your point, Kathia, this is just my stance on this. I don't know if I speak for everybody, but I feel like for special groups that we know are marginalized, I would argue that we do need to treat them differently. And in the sense where we need to treat them with more consciousness and more awareness, like they're coming into this with those fears that they're going to be treated the way that they've been treated before, or what they've seen their friends treated as. And we need to approach their care with, all right, I'm aware of this. I'm going to make sure that I'm culturally sensitive, that I'm appropriate, and that they get to see that I care about them.
I agree with you. This is something that I do in my practice now. If I know of a patient who, either because of a psych issue or other things, transgender patients especially, maybe softer, kinder, more understanding, more approachable, just because I know they may not be as forthcoming. And so I just make myself just a bit more available and more open to whatever they might need to present.
Absolutely.
And just to add to that too, I think it's really easy for all of us, to say, yeah, we just need to treat everybody the same and treat everybody with respect, and that's it. And I think it's an interesting conversation to have as far as just exploring your own biases, because it's easy to say that, but then you have this unconscious bias. We all have it, and we don't always know when it comes out or how it manifests. And I think you guys did a really good job with the way that the preceptor responded to the student too, as far as not degrading her or kind of making her feel bad necessarily, but instead trying to use this as a learning opportunity and instead explore, well, what made you react that way? And I think that we can all learn from that, and just the way that we respond to people, the way that we react to them. And sometimes it's really not as easy as just saying, oh, just treat everybody the same and you'll be fine. Because I think that unfortunately we don't always do that, even if we think we do.
Absolutely. I would agree with that too, because I feel like it has to be approached from both angles. We do have to treat everybody with kindness, respect, and dignity, but we also have to, be conscious of our own implicit biases and be able to, because I feel like that's the only way we could address any issue, whether it's racial, whether it's religious, whether it's sexual orientation, is to explore constantly, over and over again, exploring our own personal perceptions. And then when someone approaches us or enter a certain situation in which that bias might become tested, is to reevaluate again, even though we think we've approached it before, to constantly have to go through the process of reassessing our stance and our implicit views.
Yeah, and I think it's important that we're able to have these very difficult conversations. I think that's one of the big problems. We may feel a certain way about someone's behavior, and then feel uncomfortable in addressing it because it's a taboo conversation. So just being open to having difficult conversations, whether it's with your staff or families or friends, it's important. It allows us to be more aware and more regularly aware. But anyone have any additional questions or comments? So before we finish, I'm just gonna state what our roles were. So myself and Katrina worked on the ethical and legal considerations at stake in this case. Then Shanaz and Heidi worked on the decision-making framework. And then Carla and Whitney worked on the appropriate strategies for the instructor and preceptor. And all of us collectively worked on the flow of the role playing. So I thank you guys for your time. This was good.
It's a great discussion.
Yeah.
It really was. Thank you, everybody.
Thank you, everyone.
Thank you.
Yeah, thanks.
Thank you.
Thank you.
Have a
I'm
good night.
sorry for the delay, everybody. I apologize for the
It's
delay.
okay, Lindsay.
It's okay. Good night.
Night.
Still got out at 9 o'clock.
Yeah.
Good night.
Good night.